So I've come and given a talk about chemo prevention of bowel cancer, what the prospects are and what the challenges are. Well, my background to this is that with funding from the Cancer Research UK, we completed a trial of aspirin and folic acid supplements to prevent colorectal adenoma recurrence in people who had already had an adenoma removed because they had a polyp detected. At the time we did it, it was probably because of symptoms or at least by chance, not through screening. So we did this trial. It took an awful long time. When I started, my hair was black. It's now white. So it started about 1995 and we eventually had it published in January 2008. And this trial showed that if you took aspirin, you had about a reduction of about a third in your risk of developing a recurrent colorectal adenoma. And that the treatment was well tolerated, and that folate had no effect at all. Well, partly because of as I say, I started off doing epidemiology applied to gastroenterology, and I didn't actually start in cancer at all. I started in other diseases, inflammatory bowel disease, celiac disease, even peptic ulcer. And as a consequence of my involvement with this trial, I've become increasingly involved with cancer, and it probably was what led to me becoming the director of the Eastern Hub of the Bowel Cancer Screening Program. So now we're looking for other trials that we might be able to do within the framework of the Bowel Cancer Screening Program, and we currently have a trial being, we've applied for funding, for MRC funding, for a trial using icosapentaenoic acid, or in common parlance a fish oil, because there's quite a lot of laboratory and even some preliminary clinical data to suggest that fish oil supplements might reduce the risk of recurrent adenomas. And in the long run, of course, we'd like to develop a package of interventions that one might give to people who have adenomas removed as part of the bowel cancer screening and are then kept under follow-up. Because what many people probably don't appreciate is that if we screen 1,000 people, we'll have about 20 of them who turn out to have positive fecal-occult blood tests, and they'll go on to a colonoscopy. But only maybe 2 out of those 20 people will have a cancer found. And for those 2 with cancer, there will be 4 or 5 times as many that have large polyps found, and they'll be kept under surveillance and they'll need further colonoscopy. And colonoscopy is not a particularly pleasant procedure, and obviously if we could develop a package of interventions that reduce the need for colonoscopy, that'd be very attractive and might well save money as well. Well, that's a very good point, because one of the stories of the recent trials for preventing adenoma recurrence is how safety issues have come to light where none previously been suspected. And of course the most famous example is the problem with the COX-2 inhibitors, in particular with Vioxx, where it was a colorectal adenoma prevention trial which led to the recognition that Vioxx was associated with almost a 2-fold increased risk of cardiovascular events. That led to Vioxx being withdrawn from the market. So that's what happened with the COX-2 inhibitors, that the adenoma prevention trials led to the recognition that these drugs weren't as safe as we thought. But we now even have concerns with something that we thought was as safe as folic acid, where there is data from at least one American trial suggesting that folic acid might promote the development of precancerous lesions, and therefore that giving folic acid as a population intervention might not be as safe as we'd originally thought.